Okay, so we're going to move on and we're going to talk about the adaptations in the maternal respiratory system during pregnancy. So if you recall, I mentioned earlier that because of the increase in metabolism in mom and also the added metabolism of baby, right? There is this increased need for oxygen delivery to the blood by mom, which means that there's an increased need for gas exchange. Okay? So the goal is more oxygen, get more oxygen to drive metabolism. So the way this happens is we increase gas exchange, we increase oxygen delivery. So if we look at some of the basic respiratory parameters, okay, we see that some of them change, some of them stay the same, and some of them may actually change in some surprising ways. So if we look at tidal volume is the volume of restful breathing. So sort of the normal kind of breathing you do when you're sitting and not doing much of anything. It's a relatively small volume at rest. So in pregnancy, we see an increase in tidal volume by 25 to 40%, and that's mostly within the first trimester. Okay. So some women really notice this. Some women notice that they feel a little bit more breathless, right? That they are breathing a little bit more deeply. They're kind of sucking in air a little bit more. And they can feel it as early as the first trimester because it is increasing tidal volume, but they'll especially start to feel it as the baby gets bigger and as that baby starts pushing against the diaphragm and giving the mom basically less space to breathe. Respiratory rate, okay, which is really the number of breaths per minute, only slightly increases, so it's pretty stable, right? And then residual volume. Residual volume is the volume of air that is left in the lungs at the end of a maximal exhalation. Okay, so if you remember, there was some tiny airways that tended to collapse when we try to maximally exhale air, and that air gets sort of trapped in the lungs. Now, residual volume actually starts to progressively decrease during pregnancy. And that's really due to a enlargement of much of the airways during pregnancy, so that they tend to collapse less readily, right? And so you end up with less trapping of air. And so this is really an important adaptation that happens, this reduction in residual volume, because by allowing your lungs to expel as much air as possible, it also allows it to fill to a greater extent. And that decrease in residual volume helps, along with other things, helps offset this sort of impingement on the thoracic cavity by the growing baby. Total lung capacity, the total capacity of the lungs, which is the maximal volume of the lungs, is completely unchanged during pregnancy. Okay? It may not feel that way. Women often feel very breathless and that their lung capacity is decreased, but really it's actually unchanged. And so almost all of the adaptations we see in the reproductive system of mom is due to progesterone. Okay. So first off, the physical structure of the thoracic cavity in mom actually changes. So if we look at the non-pregnant position of the ribcage and the diaphragm versus the pregnant position of the ribcage and the diaphragm, what you notice is that the pregnant ribcage is wider, right, and has a larger circumference, right? It's expanded out more. And the diaphragm is displaced upwards to a certain degree. Okay? So the rib cage is wider and larger. It's displaced out, and the diaphragm is displaced upwards. Okay? Now, the reason for this displacement, okay, the reason why this displacement is possible is that progesterone, along with the prostaglandins that are released locally, and another placental hormone called relaxin. Okay? So progesterone, local prostaglandins, and relaxin, they go in and they relax all the muscles, intercostal muscles, relaxes the cartilage, it relaxes the ligaments of the thoracic cavity, and it allows for the stretching of the rib cage and the displacement, the stretching of the rib cage outward. So the stretching of the rib cage outward and the thoracic cavity outward is actually meant to counteract or compensate for this upward displacement of the diaphragm. So this upward displacement of the diaphragm that I'm drawing in right now, I'm highlighting, this is caused by, if you imagine you've got this enlarging fetus and uterus, and it's pushing against all of the abdominal organs, and it's displacing those abdominal organs up, pushing the diaphragm up. Okay? So your baby's taking up lots and lots of room, and it's pushing your diaphragm into your thoracic cavity. Now, if the rib cage didn't expand, that means that you would have a significantly lower thoracic cavity volume with which to ventilate your lungs. Okay? And that would be very detrimental, both for sustaining mom, but also for sustaining mom in this pregnant state and sustaining baby. So the expansion of the rib cage as a result of the relaxation of the muscles, cartilage, and ligaments, this expansion counter or compensates for the displacement of the diaphragm. Okay? So in addition to that, in addition to the rib cage widening and expanding, you also have relaxation of smooth muscle of the bronchiolar airways. Okay? And that basically that bronchodilation increases ventilation throughout the lungs, especially to those smaller airways, which ends up reducing residual volume. Okay. So all of this relaxation of muscle and other tissues is a result of progesterone, local prostaglandins, and relaxin. And relaxin is going to come in again. It's actually going to be important throughout pregnancy, but it's going to be especially important leading up to labor and delivery, because it's going to be responsible for making the cartilage and ligaments in the pelvis more flexible to allow for delivery of the baby. So we're going to see relaxin come up time and again over the course of the semester. Okay. We also see an increase in tidal volume that I mentioned. Okay. And that increase in tidal volume is a result of the actions of progesterone on our central and peripheral chemoreceptors. So the progesterone actually increases the sensitivity of our central and peripheral chemoreceptors, which tends to stimulate ventilation, okay, even at normal levels of oxygen and carbon dioxide and pH, and ends up causing this increase in tidal volume and this hyperventilation. And the consequence is that you end up increasing your inspired air and the ratio of inspired air to dead space. You increase your alveolar ventilation. You increase your gas exchange, the diffusion gradient across the capillaries. and you're increasing your overall gas exchange. But because women are constantly slightly hyperventilating, they're always in a persistent mild respiratory alkalosis. Okay? So because you're hyperventilating, you're blowing off more CO2 than you normally do. Your CO2 is a little bit lower, which causes a mild respiratory alkalosis. But this respiratory alkalosis, this hypocapnic state, this low CO2, actually serves an important purpose because it actually enhances the movement of CO2 from baby to mom. Okay? So from baby to mom. Because remember, CO2 can only move by passive diffusion. So baby CO2 has to be higher than maternal CO2. And so when mom decreases her CO2, it makes it easier for baby to get rid of its CO2. Okay? So this mild respiratory alkalosis helps increase gas exchange, and it also helps increase mom's gas exchange at her lungs, and it also helps increase gas exchange at the level of the placenta as well. Okay. Now, this change in pH, right? The hyperventilation leads to a mild, there's a misprint on this slide. It's not a mild acidosis, it's a mild alkalosis, right? So pH is slightly high. So this hyperventilation is leading to a mild respiratory alkalosis, and this increase in pH actually increases an important production, an important metabolite produced by the red blood cells called DPG, or diphosphoglycerate, 2,3-diphosphoglycerate. Okay. Now, what DPG does is it will shift the hemoglobin dissociation curve. Okay. Now, an increase in the hemoglobin dissociation, an increase in DPG will actually cause the hemoglobin dissociation curve to shift to the right. Okay. Now, what that means is that at any PO2 of plasma, okay, the hemoglobin saturation will be lower, which functionally means that hemoglobin tends to increase its oxygen delivery to tissues. Okay? So not only are you getting increased gas exchange and oxygen delivery to the blood, that once that hemoglobin in the blood reaches tissues, maternal tissues, the placenta, ultimately fetal tissues, okay, the increase in DPG is actually causing the shift to the right on the hemoglobin dissociation curve and the release of more oxygen at cells, which is advantageous for mom and it's advantageous for baby as well.